There we go. So, hey, everyone, this is Mary Curick with Frontrunners Innovate, and I couldn't be more blessed today to have General John J. Bartram with us, who has so much experience working with government and military side of things with the COVID, with the pandemic, and beyond that, just medical supply management and the supply chain in general. And I wanted to get into a little conversation with him about his work in that arena and some of his solutions that he sees coming. He's a very good mind about figuring out where we should go and where we should not go. And I wanted to dive into that. So, General, we were just getting ready to talk about how you get into the big pandemic and supply chain issues. And so if you want to go ahead and just start right there and let's move forward with that.
Sure. I guess first I'll just introduce myself a little bit. So I'm a retired senior executive federal employee, but I'm also Air Force Reserve Brigadier General. And last year, and I have my own company called Bright Star Innovations Group. But last year, I spent most of the year mobilized in support of the pandemic, and have since written a couple of articles on some of the innovations that were rolled out during the pandemic, and also some of the challenges that probably have been identified and need to be addressed for supply chain issues. And what I started to say just before you hit record, and I'll say it now, is that, we have to remember the scope of the pandemic is a scope that's beyond what anybody has seen before. And so a lot of these things that are criticisms that are out there on different things and blaming this person or that person and all the politicalization, to me, all that's just noise, because I don't think it was as bad as some people project, and I don't think it was, as great as other people may want to project. But a lot of it is really just noise. You have to think that this was a massive stress on not just our healthcare system, but our logistics system. We respond to a hurricane, as you had brought up, Mary, early on. And in a hurricane, it's local or regional, or maybe will be, a couple of states. And in a world of plenty, we have lots of things to throw at it and lots of different resources to do it. When you have something like the pandemic that stretches across the nation and can happen in any town, you don't have to be near the coast, or you don't have to be near the forest where the forest fire is, because it'll come to you, is that everybody has to be ready. And so from that side of it, we just have to kind of put it into a mindset that says it's bigger than what we've seen before. And so some of the structure that we had in place still works. It's just we have to modify it slightly. And that's what I found when I got over to HHS and FEMA and was mobilized and to be the deputy for the Emergency Support Function 8, which was Dr. Kadlec, under the law. He was the Assistant Secretary for Preparedness and Response, is to kind of figure out what's the structure, what are the tools, what are the resources that you have. And fortunately, Dr. Kadlec had already put in place working groups on supply, and working groups on response, and working groups on different ways to leverage the technologies that are out there. So kind of that as a background, is I just wanted to say that, just when we think about these things, think about it, that this was a whole of nation response that we've not seen in most of our lifetimes. And so that being said, and I know you want to talk about the supply chain part, and I'm happy to talk about that. Do you want to?
Thank you for introducing. I had some notes to introduce you, but I got too far into the conversation to do that. But thank you. Yeah, your work with Bright Star. Can you give us a little bit of a capsule on what you do there, what the innovation part of that is?
So I work with a number of corporations and entities, and I've even worked with the federal government as to help them identify things that are coming around the corner. The next version of technology and the next version of items that are out there. And so previously, actually, to me being mobilized, I had actually been doing some work with HHS on some of the innovations that they actually used during the COVID response. And so there's a technology out there to be able to do dialysis at home by connecting a device to your sink. And that really can disrupt the entire market. And looking at how do you expand out? Now, hindsight today, but a year and a half ago, I may have been one of, I was only one of probably about, 20 or 30 people talking about how you can leverage what I call virtual healthcare. A lot of people call telemedicine.
Yeah.
Because, about 80 to 90% of your urgent care visits could be done at home, and they weren't being done. So looking at those types of technologies and just trying to think creatively, and how do you leverage technology towards the future. And that's kind of, if you look up on the National Academy of Public Administrators, there's an article out there on innovation that I published in January, highlighting a number of those. And then the one that I think you caught your eye was on the supply chain, where I talk about some of those types of things from a policy side, what can be done differently, and also from a practical side, what could be done differently.
And I think that's what's, it takes both sides. You can't do one without the other. You just won an award in April with I think it was the American Hospital Association Award for all the work that you've been doing to kind of help save lives. So thank you for that. Where do you see us with the innovations? I mean, some innovations are more acceptable than others, but when I look at the pandemic, I see some things that have, like you said, telemedicine, that are going to probably continue on past the pandemic, because it worked to save time for a lot of the physicians, and it helped create a situation where it's healthier for everybody. If not everybody has to come and sit in somebody's waiting room for that are all very sick anyway. So I see some of those things rolling forward. It just brought those to the surface in a way that a lot of people never thought they'd have to do. My husband, who still uses a flip phone, can't figure out what to do when his doctor is saying, I need to see you by Zoom. And I'm like, I'm the one that has to do that. So there's still the old mindsets out there that we'll overcome. But what do you see is going to be the big breakthrough for us to kind of look at in the coming months and maybe the coming year or two, as we look at really preparing ourselves for the future of maybe potentially other situations like this?
So I think virtual healthcare is going to kind of, and I use the word virtual healthcare because I think it's more relevant to telehealthcare, because telehealth kind of goes back to the 1950s and 60s when you had two closed caption TVs that was, in virtually telemedicine really was, a conference call where you were calling. Yeah. But I think with virtual healthcare, we're seeing lots of technology come down the line and get further developed and adopted, that allows you to do ultrasounds, via this type of technology right here. You can use things that are on your smartphone to get
vitals,
pulse ox or cardiac. So the provider on the other side can have a lot more information than they would. So it's not just a well visit check to see how you are. And I think we'll see an expansion of, there's a field of medicine called wilderness medicine, where you look at different types of technologies when people are out on their own, and they, and you can call back and say, well, you're having a pain in your abdomen. Is it appendicitis? Can you jump up and down? And what doctors tell me is, if you can jump up and down, you probably don't have appendicitis, and so that way they'll kind of know how to triage you and work that. So I think that the virtual healthcare is going to be very positive. Where I think virtual healthcare is probably going to go is out of the hospital to where doctors don't have to be clinically based in a hospital. And so when you think about the cost of a clinical center, the square footage cost of a clinical center is 4 or 5 times the square footage cost of a administrative building, because you have all the life safety things that you have to put in it. And so you have to have oxygen, you have to have, special things that meet the hospital codes, because you have patients that are in those hospitals. But if you and I were running a hospital, would we really, if we were going to do virtual healthcare, would we have our doctors in that high cost square foot for the hospital? Or would we put them across town in an administrative room, or maybe let them work where they want to work, as long as they have access to the electronic health record? Because if you get access to the electronic health record, and you can get access to the patient via a platform technology, and there's a number of platform technologies out there that are designed just for healthcare. And Milton, a friend of mine, has got vSync, and that's a technology that's kind of a Zoom type platform that's just for that type of healthcare. But think about how you can expand that out. And why, let's say that you go to a Minute Clinic at your local CVS, Rite Aid, or whatever. There's no reason they can't have a kiosk there where they can dial up Dr. Mary or nurse practitioner Mary and say, and get a consult right there and get the prescription written right there, or Walmart, so you come in and you can, so I think that's where the technology is going to go, which I think will reduce the overall cost of healthcare. And I think there's going to be some structural changes that relate to that. It'll be interesting to see how that rolls out. The technology that was used in New York on the dialysis machines that the Assistant Secretary of Preparedness had the foresight to kind of invest in. I think that technology can expand out, and you might not have as many people going to dialysis facilities. Because if you can get it at home and you don't have to travel,
I know.
How much better will that be? And so there's another number of other things that are, sorry about that, my daughter's upstairs. There's a number of other things that are going on around, around the innovation. There's a company called Appiject, which Jay Walker, who is from Priceline originally, and really a great inventor in himself, that they came up with a kind of going back to the future, a technology where it's a pre-filled syringe that's in a new, in a 1950s technology, blow fill technology that is able to fill at a much faster rate and be a fill finish where it's actually in a syringe. And then you could give yourself an injection, or if you were in a third world country and you were trying to give a vaccination, to be able to have these, they're all pre-filled. It saves on the time to fill. It saves on the time of pre-measuring. It prevents secondary infections because you have a clean needle with each stick.
Yeah.
And they put an RFI technology in that process so that you can scan it, and then you can report all the information back up or to the electronic health record, and or to let people know where vaccines are going. So I think there's a lot of technologies that are coming out of this that are either seen or not seen, and those are things that are out there. But I think it also identified a number of weaknesses in the structure of the system.
Yeah.
And on the preparedness and response, there's been a discussion for years from when I used to work in the House of Representatives that deal with what's called the last mile. How do you get items to the last mile? And how do you get something to you when you need it, where the event is? And there's some technologies that are being developed. Jeffrey Lang and the pharmaceutical pharmacy on demand program, that company that they've got out there, which potentially has the ability to change the entire dynamic of how healthcare, of how medicine is delivered. Because if they're right in what they're trying to do, a lot of your medications could be manufactured, from a small thing about the size of a microwave at the pharmacy. And so you don't have the whole distribution and logistics system of shipping all of that out. And similar type of things of looking at rehydration fluids that could be dry, or having them so that they can be rehydrated or manufactured, in the hospital setting, to kind of deal with that.
Get away from the refrigeration nightmares that have happened a few times.
Well, also it expands the production base. So if you think about saline, when there was a hurricane that wiped out the production facility in Puerto Rico, it caused a shortage. So if now you can distribute the production facility for some of these technologies across the country, you don't have to worry about a plant getting taken out in X place or Y place by a natural event or by a power outage, and it diversifies your ability to respond. And that kind of leads into the article
Yes.
which I think is where you were wanting to go,
Yeah,
Mary.
you brought up the best point. Then part of the supply chain situation had to do with us having to get things from other countries that, um, we won't go into all the why things happen the way they did, but basically weren't in the best interest of us here in this country, in the United States. But what do you think? What went wrong? What went well? What could we do better to make it, not be so chaotic maybe the next time?
Well, I mean, we live in a diversified world with a diversified supply chain and a diversified market, and so decisions have been made over time based on economic and environmental that we're not going to produce this type of, say, some of the APIs, like 70% of the active pharmaceutical ingredients are not manufactured here in the US. And there are economic and environmental reasons why people have chosen not to do that. Because there's different laws that say, you've got to meet certain standards. And so that has shifted abroad. And so those items are shifted abroad, and people have raised the noise about that over time. Hey, we need to shift some of that back. And what I'm hoping will come out of this is looking at different ways to manufacture those. So, are there ways to change the chemistry, because it's really just a chemistry project? Are there ways to do that so that you can manufacture API in a different way here, as opposed to having it overseas, or take the if you take nitrile gloves, the medical exam gloves that most people use, a little known fact is that was actually invented in New Hampshire, if I'm not mistaken, by a 90-some-year-old gentleman who'd been in the glove factory business for years and years, and a few decades ago. Well, now the majority of them are made in Central Asia and, in China and Thailand and Malaysia. And that shifted, that market had shifted. But is there a way not just to bring the factory back, but to bring the ability to make the raw material back? And so,
Yes.
there are discussions going on, at least I'm having those discussions and with Brightstar with people about how can we reimagine how that's being done? How can we do it differently so that we can manufacture that at the front end, and maybe like the pharmacy on demand, distribute that out so that it's manufactured, because the rubberized material that you need there, that NBR, that's used in lots of other commercial aerospace and other national security spaces as well. So there are some people say, well, let's just stockpile it here. Stockpiling, it's not a bad way to do it until you can get to that. But eventually you want to be able to bring home that type of technology so that you can manufacture it here. But cost and labor and production, all of those functions, play into it. And that's what caused me on the one of the items in my article was about just-in-time or stockless production systems, and what I call a supply bubble is that hospitals have rightfully moved into this just-in-time and stockless inventory, because it lowers the cost of healthcare. And I wouldn't want to see them move away from that at large, because you don't need large warehouses with every hospital around the country.
Mm-hmm.
But maybe there's an opportunity here for critical items that would be needed during a response, where they hold a supply bubble of 45, 90 days of that type of supply, as opposed to the just-in-time inventory that might be 3 to 15 days that they hold. And so what that could do is what we saw happen in March, when everybody saw that the pandemic was coming. Every hospital, and if I was a hospital administrator at the time, I would have done the exact same thing, hit the reorder, so that they could get their supplies in and their stocks in before everything went out. Well, that sent a demand signal and to the middlemen, and they didn't have that level of stock because they weren't used to having that level of stock. So if everybody would have had a 90-day supply of their normal routine level for masks, it would have at least given them, even if they had the outbreak there, probably about a 30-day or 45-day window to be able to, as a cushion. And it would have also have given a larger supply across the country for hospital systems to re-level within the hospital. And so so one of the things that I'd suggested in the article was just that is, can we come up with a federal policy through the Centers for Medicare and Medicaid that because almost all of the hospitals are part of Medicare and the Medicare program, over 6,000 of them. And so just like Medicare puts quality and safety standards out there for hospitals to protect their beneficiaries, I see no reason, at least in my little head, why they couldn't put a policy out that if you want to be a Medicare provider for these 15 or 20 types of items, for N95s or gloves, things like that would be used in an emergency, you have to keep a 45 or a 90-day window of supply on hand.
Yeah.
And CMS actually has mechanisms to help kind of cover the initial financing cost, because you're going to buy those items anyway. So it's not a new cost to you over that window, but it is a financing and a carrying cost. And so I think there are avenues, in that. So, I mean, I'll kind of stop there and see if you had any thoughts on that. Or.
Well, I kind of wanted to go to sort of a localized, question in terms of one of the things that we kept seeing was the purchase order processes that everybody kept saying were antiquated, and it took so long for them to get through a process that they were not seeing the people, the vendors, kind of had the control on what was going to come or not come. And a lot of the, quotes expired and things like that I saw happening around. I actually interviewed IBM's Watson Health back in April of last year on the blockchain solution that they came up with that really went nowhere. They already had a supply chain solution for blockchain for just general purposes. It was out there for the medical community, and they kind of boosted it up for the pandemic and worked with, believe it or not, somebody out of the fashion industry in New York who, had already been working on supply chain issues. And they put something together that I'm sure didn't last more than 20 minutes, mainly because they required so much out of vendors who didn't think that they had to do anything to prove themselves, So they were already getting orders. They were trying to deal with the trust issue, between vendor and, buyer. So, but the PO processes seemed to be the thing that was slowing everything down. And even at the government level, I know they had that, but they could overcome that. When you're the White House, you overcome whatever you need to. But do you have any thoughts on that?
So I don't disagree with you that there is a market integrity challenge out there, especially as we've been in this large demand. I mean, I read something a few weeks ago that said that last year the number of nitrile gloves, the demand in the U.S. increased by 300% from 2019, and I think that's probably true. Same thing could be said early on about N95s, but there's a process where you have to validate what's coming and what's not coming. And when everybody hit reorder at the same time and it broke the supply chain, there's a lag time from how fast producers and manufacturers can add capacity.
Yeah.
Sometimes you can add capacity by just adding a third shift. You might have two shifts going. You can increase it by 1/3 by adding another shift once you hire people and bring them in. But there's still a lag time. There's still capital cost to that. But then others, you have other people who are bringing on new manufacturing lines. And the fortunate thing for some of this PPE, it's not an extremely expensive capital to get some of these started, as we've seen in some of the gloves and some of the masks and things like that are out there, is that you can add those relatively quick, but relatively quick is still not overnight.
Yeah.
And so you've got to balance that issue of, I've got 100 items to sell and I got 1,000 requests. And so the way the suppliers were doing it, and they've done it over time, as I understand it, whenever there's been a shortage, they allocate it to the people who bought it. So if they've had 15 people buying it, they'll allocate that 100 based on, the pro rata share of what they bought in the past. So everybody gets something. The challenge is that now you got new players coming in, or people who don't normally buy, like nursing homes that want to have some of this PPE, and so that they didn't get it. But kind of leaping forward a little bit, not kind of going down the past, is how do you put more integrity in that market, so that the items that are coming over are not gray market items that are made illegally? How do you build the trust and integrity into the system, so that the FDA has a process where it's called 510K. You have to have this approval for certain types of medical devices that you're going to sell. How do I know that there really is a 510K for the product that you're making, and that you really have authority to use that 510K? Right now, and one of the things that I've been doing through my company is helping some particular associates of mine go out and do production allocations. It takes us sometimes 5-6 weeks to validate all of that information.
Mhm.
But if we had a set standard where we used blockchain combined with some other technology like RFI or any of these type of micro antennas that you can scan them at the box, and you'd be able to look back and see, not just where it came from, but the 510Ks are valid, the financiers on the other end, and you could do a total cradle to grave. To me, that's how I think you bring that in, because a blockchain is really a decentralized record of a ledger of transactions. So every step is cryptologically, technology ties it to that, and it's locked in, and it really can't be altered, as I understand it. And I'd be the first one to say I'm
validated, and it can't be altered. So you're right. And honestly, I think what you're talking about is, I think if Watson Health had started this before we got into pandemic, we would have been in a good place. What you're talking about, I think, is where they were aiming, is get that trust and validate every piece that needs to be validated with the right vendors, so that hospitals could go to an entity like that or a platform like that and know that who I'm getting to is the right source, and everything's been check marked, if you will, and nothing can be changed once it's in there. I think the thing is, once we got thrown into it, there just was almost no hope about pedaling backwards.
Well, yeah, I think it's hard to build that. I mean, I was, in some ways, some of the stuff we were doing, because of the massive scope of this. Fortunately, we had a racetrack built, and we had chassis and parts that we could plug in, but we probably didn't have the exact car that we needed.
Yeah.
And we built the race car we could build the
best we could do. Yeah.
But adding this turbocharger onto it probably wasn't going to be feasible.
It was not going to be
at the time. But that doesn't mean that we can't do it now.
Yeah.
And I think one of the challenges that I've seen from my company's perspective is, I've talked to a couple of companies that they all have their own thing. Mm-hmm. So, IBM has its thing, company X has its thing, company Y has its thing. I think what we need to do is we need to kind of build a coalition of a number of these companies to identify a set standard of what a blockchain would look like, and how you could plug in any type of technology, physical system technology, like a scanner of some sort, an RFID type of technology, or I think I heard one the other day of a NCI or NCR type of technology. But any of these types of things could plug into that. And it, in my mind, it's no different than the work I did years and years ago on interoperable healthcare records. There were lots and lots of standards for labs. And when I was working in the Office of Management and Budget, we had partnered with some of these coalitions and associations to say, what would be a good standard for the laboratory that could be fed into a electronic health record that could then become interoperable, so that when you get your lab, that data can transfer back and forth. And I'll be the first one to tell you, I don't know that we have fully interoperable healthcare records yet, but we're much closer than we were 20 years ago. And I think that instead of each one of these pick your name of your company, deciding that this is what their blockchain is going to be. If we can build a coalition to come together and say, let's put together a standard, then let's go to the government. And it's similar to how the joint accreditation does for hospitals that get rated for safety. That, that's a kind of a not-for-profit type of organization. It's not a government entity. And they come up with a standard, and it's adopted and used by CMS to certify you as being a Medicare certified hospital. You have to meet that standard. And so it's kind of blessed through them. Well, I think the same thing can be done here, is if we get the right companies in the room, and I think the right companies are the IBMs and smaller companies, and say, what are the characteristics that you'd want to have in that ledger?
Yeah,
that makes sense. That everybody would agree that these are the characteristics that we'd have. And where are the plug-in points? Where does it start? How do we plug in the FDA 510K if we're talking about the medical chain? And if we did that on the medical side, it could become the platform that could then be used, quite frankly, throughout any part of the supply chain, not just the medical supply chain.
yeah, yeah.
But then you could come to the government and meet with so the Federal Acquisition Regulation, or what's called the FAR, that document is, as I understand it, is controlled by DoD, NASA, and GSA. So then you can have a discussion with them and get it adopted into the FAR. Now, the government, as I've been told by a number of people, buys about 4% of the medical PPE. Yeah. Which is not a significant amount. But if they put it in the FAR and said that if you're going to sell to the government, you need to adopt this industry standard, and that, I think it would drive the adoption even faster to a lot of these companies, because most of the larger companies want to sell to the government. And so I think that it would help drive that standard and get it implemented. So I think that there are ways to do that, but it's just, it's not going to be, it's not likely going to be one company driving the solution by themselves.
Although I do think you just outlined a new project for your company. So I heard it. I saw it coming.
Well,
I'll tell you that, right?
I can say that off the top of my tongue, because I've had that conversation 3 or 4 times in the past week. And if anybody wants to talk about it, let me know, because I think
maybe I have a connection for you. I think I need to hook up IBM.
Yeah, I think I may be trying to put together a coalition based on the conversation.
Well, actually, the connecting point for me at Watson Health is one of IBM's legal eagles. So it's a lawyer from IBM. It was helping her. She's awesome. So I may have to connect you too. Yeah. But thank you so much. This has been a great conversation to have, and I feel like there should be more down the road. But we'll take a break here, and then maybe I can come back later and see what other awards you won for cool things that you're doing, because I have a feeling there's so much innovation that needs to happen to move things forward for not only our country, but the world. There's so many, we're in a lot better place than some of the other countries are right now. I've got people in India I'm talking to every day that just scares me to death for them. My heart just bleeds for what they're having to go through. But anyway, I want to stop it here and just say thank you so much. I appreciate the conversation and the ideas and the thought leadership that you're putting out there, and just keep doing it. If there's any people that I come across that, and I know at least 1 or 2 right now that I need to shift your way, definitely do so. We're going to drop in the link to, I assume we have a website link for Brightstar Innovation, and grab that in your LinkedIn profile so that people can know a little bit more about you and what you're doing. So thank you again. I appreciate it.
Thanks, Mary.
All right, no problem.